All right, everybody. I'm going to do another lecture here. So, the topic of this lecture is mixed depression. And, in this unit, we're covering the mood disorders. So, that's kind of inclusive of depressive disorders and bipolar disorder. And as I kind of mentioned in my last lecture, I like that manic depression kind of nosology, that diagnostic that we don't really use in the DSM era. But again, it's that kind of understanding of both unipolar and bipolar depressions as part of the same family of disorders. Now, mixed depression definitely fits into that. So while we're not doing a dedicated lecture to bipolar, because you have a lot of good information about bipolar disorder, this is one of those areas where things get muddy and the clean lines that are kind of artificially created in the DSM-5, it's a little bit different when you're on the ground, and I really like this mixed depression slide set. So I think you're going to get a lot out of this. Again, this is a Neuroscience Education Institute slide deck, NEI. As a member, I have their permission to use these for educational purposes, so we are in line with all copyright. The words are my own, and I will comment as appropriate. So this is just kind of an illustration of the mood disorder spectrum. So this is where a way of looking at mood disorders as starting with depression on one end, mania on the other, mixed state in the middle. So it's not an issue of co-occurring MDD and bipolar. And just as a point of diagnosis, there's no such thing as co-occurring comorbid MDD and bipolar. Okay, if you're depressed, you have. But if you have that cyclic depression, that is a honestly a manic depression picture, but if it's alternating with mania, then you're clearly in a bipolar syndrome or a bipolar 2 if it's a depression with the potential for hypomanic states. Depression, kind of on the far end, is kind of, I think they're leaning along the lines of a dysthymia or a melancholic depression that's just always there. But again, this presentation really talks well of just looking at this as a spectrum, and there is that mixed state in the middle where there is depression along with what we would consider manic symptoms. So here you're just looking at the amount of patients that convert to bipolar disorder during follow-up. So these are people progressing, quote unquote, from MDD with a subthreshold hypomania to full-on bipolar disorder, which to my mind pretty much says they were always in a form of bipolar disorder. They were always in that manic depressive picture. So here we go, clues across the spectrum. You're definitely looking for that family history of bipolar disorder. So manic depression and schizophrenia are two highly genetically driven psychiatric syndromes. So you always want to look for that family history, the early age of onset of your first depressive episode, etc. So you can kind of look here and look at their clinical history, their treatment history, and their symptoms. And you'll notice under the treatment history in particular, worse response to antidepressants. And what do we learn over and over again? The risk with giving an antidepressant medication to somebody with an underlying manic depressive or bipolar disorder is that you can actually trigger mania. So here we go, we even have antidepressant induced hypomania. And then symptoms, things like psychotic features, atypical depressive symptoms, those are your agitation symptoms. Subsyndromal hypomanic symptoms, so they kind of have that hypomania that doesn't meet those technical definitions. And then all those things that go along with that, impulsivity, aggression, hostility, and comorbid substance use disorder. So again, kind of think of this again. So you have this patient that's been given this DSM-5 diagnosis of MDD. They came in, they said they were depressed, they're being treated for depression, then they start having these other symptoms, these agitation symptoms. They're aggressive, they're impulsive, but they don't meet the book definition of hypomania. So what do we call that? We just call that an atypical depression. Well, what is atypical depression? What is a clinical condition that is the complete opposite of the basic definition? So, depression is essentially psychomotor slowing. It's slowing of thought, it's slowing of affect, it's physical slowing. And so, if you have somebody that's supposedly depressed, but now you're getting these agitation and almost submanic symptoms, how does that fit into the depressive picture? And that's where this mixed state comes in. So, And this is kind of what we're going through, and I kind of talked over this. But again, these are those symptoms that we're looking at that just don't seem to fit in to our overall picture. So there's our response to antidepressants, our hypomania, etc. So you get some diagnostic conversion from MDD to BD. So you get a third of patients that are showing converting from MDD to bipolar disorder. And again, that just doesn't quite make sense if these are two distinct disease states. You don't convert from diabetes to chronic lung disease. Those are two distinct different diseases. So again, we've got our age of onset among the converters, again, is a bit younger than the non-converters. And again, this meets with our picture of bipolar disorders coming on earlier than depression. Weeks spent in the psychiatric hospital, again, those that supposedly convert to bipolar are having a much more severe clinical picture. They're having more hospitalizations. Um, and here's where we go. So we're going with DSM-5 diagnoses. So if you're having this depression, you're going to be diagnosed with major depressive disorder, what I'm calling unipolar depression. And then if you have depression, but you have some of these manic symptoms, now all of a sudden you're bipolar too, because you're mainly depressed, but you have some hypomania. Um, and so if these hypomanic symptoms occur at the same time as the depression, we call that mixed features. And then again, if you're having true mania, then you're diagnosed with bipolar disorder 1. And again, it's mixed features if you're getting depressive symptoms with the manic episodes. So in the DSM-4, a mixed episode met the diagnostic criteria for major depression and the mania met at the same time. Now in DSM-5, this is changed to a mixed feature specifier, which recognizes the presence of the subthreshold hypomanic symptoms during a depressive episode. And the specifier may be applied to major depressive disorder, bipolar 2, or bipolar 1. So it's kind of this little workaround of saying, well, you can have major depressive disorder with some mania involved, and is that really still major depressive disorder? So the specifier in DSM-5, and it's worth the while to spend a little time at this because it's saying full criteria for the major depressive episode with greater than or equal to 3 of these manic symptoms. So your elevated expansive mood, inflated self-esteem or grandiosity, more talkative than usual or pressure to keep talking, flight of ideas or racing thoughts, increase in energy or goal-directed activity, increase in excessive involvement in activities with high potential for painful consequences. This is your risky behavior, and decreased need of sleep. The diagnosis may be complicated by comorbid conditions, including untreated ADHD, personality disorders, and substance abuse. And I'll just say aside that what the DSM-5 is definitely does not do, it does not have a true diagnostic category hierarchy. So it doesn't kind of have which is an inclusive diagnosis of others. And I would say that if somebody is having mood disorders with this many manic symptoms, is there such a thing as untreated ADHD, personality disorders, and substance abuse in this patient, or are those things all symptoms of the underlying bipolar manic depressive diagnosis? So you can have a core part of bipolar disorder is difficulty concentrating. So there's your ADHD. Your personality disorders, difficulty in interpersonal relationships, substance abuse with that risky behavior. So you kind of get to the point where you're layering on these comorbidities that could have been explained by that number one diagnosis. If you have, going back to a medical example, if you have a diagnosis of pneumonia, you also don't have a separate diagnosis of fever and a separate diagnosis of a cough disorder. Those are all part and parcel of pneumonia. Likewise, attentional deficits, difficulty in interpersonal relations, and propensity to substance use are part of manic depressive disorder. So just again, always want to put that in your head. So are mixed features the exception or the rule? So commonly encountered in adults with both major depressive disorder and bipolar disorder. So if they met a criteria for mixed features during an index major depressive episode, so 25% of those with major depressive disorder, 34% of those with bipolar 2, and 33.8% of those with bipolar 1. So this, to me, just points to a specific disease entity and not a comorbid condition. So depression with mixed features, DMX, um, the initials you will see for this in this talk and as reflected in the quiz. So you're looking at, so what we have, a family history of bipolar, suicidality, antidepressant-induced mania, young age of onset, long duration of illness, poor prognosis, severe depression, antidepressant resistance, more common in females with a comorbid anxiety, comorbid substance use disorder, and impulse control. So, that to me is the definition of bipolar disorder. So it's interesting that just because there's a heavy depressive um, element to it, and because we've gotten away from the manic depressive diagnostic category that includes unipolar depression, which is primarily severe depression, we now have to say that it's this unique depression with mixed features with all these associations, when those associations are defining characteristics of bipolar disorder, or at least very common characteristics of bipolar disorder. So what symptoms are most commonly seen? So we have irritability, distraction, the psychomotor agitation, racing thoughts, increased talkativeness, emotional lability, rumination, initial or middle insomnia, dramatic expressions of suffering, impulsivity, and risky behaviors. So this is based on some of the very fundamental research in depression with mixed features, and that is going to be, you'll see those names at the bottom, Benazzi and Kokopoulos in particular did a lot of the fundamental research on this syndrome. So we have here your, these are your symptoms, and these are how frequently they're seen. And you'll see some of the top ones are your psychomotor agitation, your irritability, and your distractibility. So the point of this is those most common symptoms, they are excluded from the DSM-5 mixed features criteria due to the overlap of these symptoms with other disorders such as anxiety disorders and between mania and depression. So the point being, you are seeing these symptoms, but they were artificially excluded from the DSM-5 because you wouldn't be able to kind of force it into the DSM-5 criteria, which remember, DSM-5 criteria are not science-based. DSM-5 criteria are based on consensus and they're based on reliability, meaning if you give a list of symptoms, you can get different experts to agree that those describe a single syndrome. So it's a consensus-based, not a science-based diagnostic system. So the experts are arguing that these three particular symptoms are the defining features of depression with mixed features, and excluding them will lead to misdiagnosis and dangerous treatment strategies. So ding, 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 this is something to be paying attention to. Imagine if we excluded psychosis as a diagnostic feature of schizophrenia. So yeah, so you have this mixed state, you have this depression with these bipolar manic elements, but you're leaving out irritability, distractibility, and psychomotor agitation. So it's really going to leave you to the potential of misdiagnosis while they're including rare symptoms such as an inflated self-esteem and elevated mood. Well, that doesn't occur very much in these mixed states, so why include it in the criteria but leave out these important three symptoms? So the non-DSM criteria for depression with mixed states that you should definitely be aware of do not exclude agitation, irritability, or distractibility. Benazzi's criteria was greater than or equal to 3 signs and symptoms of hypomania plus depression. So if you had 3 signs or symptoms of hypomania, including agitation, irritability, or distractibility plus depression, it was a diagnosis of depression with mixed states. Kokopoulos, again, his criteria was depression with agitation, irritability, and that mood lability. And these match the research-based diagnostic criteria. So you want to consider that family history and you want to consider the age of onset of depression. Remember, mania, bipolar disorder comes on early. The melancholic depression that we kind of think of as major depressive disorder comes on later. Likewise, strong family history of the bipolar disorders, not as genetically linked, is depression. Has much less of a genetic link. So if you use this criteria, you get 4 times as many cases of depression with mixed features. So we're clearly missing a diagnostic category here. So you have the specificity and the sensitivity are much higher. using the Benazzi versus the DSM. So So all patients identified as depression with mixed symptoms will indeed have that in the DSM criteria. So to clarify, so it's 100% specific because that's the criteria used. So if you use those criteria to diagnose, you're going to have 100% specificity. However, only 5.1% of all the individuals with depression with mixed features will be identified because you're missing those other criteria. And that leaves you with 95% at risk of receiving inappropriate treatment. So that's the 100% specificity, 5% sensitivity for the DSM criteria for depression with mixed features. Now, if you use the Benazzi criteria, you're going to have only 10% of patients identified as depression with mixed syndromes will not actually have that. So you only have 10% that are in that incorrect and less than 50% at risk of receiving the inappropriate treatment. So that's a big difference. So what is potentially more detrimental? Misdiagnosing someone who is pure unipolar as depression with mixed features, or treating unidentified DMX with antidepressants? Now, the answer to this is, if you think it through, if you misdiagnose someone who is pure unipolar as depression with mixed features, you're probably going to be putting them on a mood stabilizer. DMX kind of falls within that unipolar depression, manic depressive picture, in which mood stabilizers are probably going to be a good treatment choice. And thinking back to our lecture on the SRIs and antidepressant treatments, when only a third of those work on the first go, 67% work after several trials, which is usually augmented by mood stabilizers, you're probably going with the right treatment right off the bat, even if you misdiagnose someone as having depression with mixed features, you're probably doing them a favor by putting them on a mood stabilizer instead of an SRI. Versus if you're treating unidentified DMX with antidepressants, well, what are you doing? You're taking someone that you think is a doctrinaire major depressive disorder, you're putting them on SRIs or other antidepressants, and you could very likely trigger mania. And triggered mania can lead to many, many negative effects, not the least of which is suicide. So I think this is kind of an opinion question, but I think it's pretty clear you're much better off treating someone who has a pure unipolar depression with mood stabilizers because you misdiagnosed them as having DMX, versus treating, someone that is DMX and you don't know it, but just treating them with antidepressants. So what is the consequences of misdiagnosis? Years, often a decade or more of unnecessary suffering. They develop treatment resistance, so you just keep hammering them away with antidepressants. They're not doing any good. They're going into that STAR-D pathway that we talked about last time of multiple antidepressant trials. And in that, you're getting that reduced likelihood of responding to eventual appropriate mood stabilizer treatment. There is some evidence that as time goes by, that condition is worsening, you're not treating it appropriately, and they may be less responsive to the proper treatment down the road. Treatment emergent activation syndrome, TEAS, that's what we're talking about when you give an antidepressant, you trigger mania. And again, suicidality, the bottom line, the condition that kills our patients in psychiatry. So it's a very serious issue. So treatment resistance, as we met before. The depression with mixed states are less likely to respond to treatment as usual for major depressive disorder because they don't really have, or they don't have kind of a melancholic depression that does respond to antidepressants. Diagnostic conversion from unipolar to bipolar is significantly related to treatment resistance. Approximately half the patient with treatment-resistant quote-unquote unipolar depression may actually be bipolar, and that's kind of the underlying point of all of this. Bipolar doesn't mean you're seeing mania all the time. You may only be seeing depression with recurrent depression with periods of normality in between. That's that manic depressive picture. It's that recurrence that's the defining factor. So they were just waiting to be triggered into the bipolar. And that this repeated exposure to antidepressants may lead to resistance to mood stabilizers and poor outcomes in patients without pure unipolar depression. So, and it may also be that patients with more antidepressant trials were always going to be resistant. That's what we talked about in the last in the last lecture, what other disease state do we have where you just do trial after trial after trial of the medication of choice, the classification of medication of choice, just keep trying different monoamine agonists, all these different monoamine agonists, which are the SRIs, the TCAs, the MAOIs, and they're just not working. So are you treating the right disorder? So over 20% of patients may experience treatment emergent activation syndrome on these medications. It's most common with the SNRIs and the tricyclics. And what do the SNRIs and the tricyclics have in common? They have a really heavy norepinephrine agonist behavior and reuptake inhibition behavior. So you're giving someone that has a propensity to mania, you're kind of pounding them with stimulants, and that's what's going to trigger that. It's hypothetically related to high noradrenergic potency, so that's kind of what I just said. Presence of even minor subthreshold hypomania during a depressive episode increases the risk of TEAS. So this is your patient. If they have depression, but they're having these periods of what looks to you like hypomania, but it doesn't meet the book definition in terms of frequency, but they're having these expansive moods, these big boosts of energy, and either big boosts of positive energy or big boosts of irritation, agitation. Really, that needs to increase your awareness that you may be looking at someone who is not major depressive disorder, who isn't a pure unipolar depression, who actually has this propensity for hypomania or mania. And if you're giving them the standard monoamine agonists, if you're giving them SRIs, SNRIs, TCAs, you could be triggering mania in these patients. So you want to be very aware of that. So higher risk of this treatment syndrome. So TCAs or SNRIs, absence of an anti-manic mood stabilizer. So, if they're one of these patients that are on an augmented, and at least you have them on lithium or lamotrigine or any carbamazepine or any of the mood stabilizers, you can actually be working at cross purposes there if they're on both meds. And there's some good research for that. And I actually posted some of that in an earlier module. But at the very least, you're kind of protecting them. And so if they're not even on that mood stabilizer, you're really at the risk of triggering mania. Genetic factors, which I just got done saying, bipolar has a very strong genetic basis. Comorbid alcoholism, female gender and comorbid anxiety disorder. Well, bipolar is more common among females, and anxiety is a symptom of bipolar. And this is just one of those things I want to keep getting across to you, that unlike other areas of medicine, of healthcare diagnoses, in psych, we just layer on these. And I know you've seen this, and I wonder if you've wondered about it. You just layer on, like, okay, the patient has, because they're on each med needs a diagnosis, right? So your patient has a diagnosis of major depressive disorder plus ADHD, plus generalized anxiety disorder, plus PTSD. And is it really that they have 5 distinct medical psychiatric disorders, or is there one major disorder that's causing all these symptoms? That's the idea of diagnostic hierarchy. If you can get one diagnosis to cover all of these, so if you have a patient that has issues with insulin production, and they also have issues with weight loss, and they have high acidic acetone in their urine, and they have acetone in their breath, they have all these things. Do they have 5 different diagnoses, or do they have type 1 diabetes? Well, they have type 1 diabetes, and why is it not the same in psychiatry? If you have bipolar disorder, you have a patient that has periods of depression, they have anxiety, they have difficulty paying attention, they have a propensity to substance use disorder, and on and on. That doesn't mean that those patients automatically have bipolar disorder, but I want you to really get in the habit of looking for what is the single diagnosis I can make that has a genetic component, has a predictable course, has a predictable reaction to treatment, and that covers all these symptoms I'm looking at. So continuing, I think you get the point by now. So bipolar 1, greater risk than bipolar 2, a history of antidepressant-induced mania, mixed depression, they get a low thyroid stimulating hormone with TCA use, and a hyperthymic temperament. Now, we haven't really gone into temperaments. Um, I'm sure you've seen cyclothymia and dysthymia in DSM-5. And what these concepts refer to, these are personality traits. So we're not talking the artificial constructs of personality disorders. We're rather looking at traits. So if somebody has sort of a baseline temperament, hyperthymic means they tend to be kind of up. Dysthymic means those people that are just kind of chronically depressed. And then cyclothymic, which is not included in DSM, but it definitely fits in this picture, is the people that just as part of a personality, they tend to go up and down. So it may not meet the criteria of a bipolar disorder, but they tend to be up, down, kind of rapidly. Those are the temperaments. So dysthymic, hyperthymic, and cyclothymic. So um, depression, mixed states, and suicidality. I've mentioned this. So all these things are a recipe for suicidality, the non-euphoric hypomanic symptoms. So, and the euphoric type, I think we are kind of are over predicted in some of our writings, but when you really meet these patients in person, because when you see it on paper, it kind of seems like, wow, hypomania means I'm in a really good mood and I have a lot of energy and I'm getting a lot of things done. Now, mania, oh yeah, I don't want that because that's where all these dangerous behaviors come in. But hypomania, you look at it on paper and it seems like, wow, that doesn't seem like too bad. That sounds like a productive person. And there is a percentage of people that have that level of hypomania. And there's even more common than that if they do have kind of that euphoric hypomania, that it's mixed. They have some of these non-euphoric symptoms, but in actual practice, what really happens is most of it is the non-euphoric. So it's not like it looks on paper. These are patients that, yeah, maybe they get these boosts of energy, but they also get these boosts of agitation and impulsivity, and they're irritable and their thoughts are racing and they just can't get things done. And again, this is sub-threshold. This isn't meeting the full mania criteria, but it's an unpleasant state. It's unpleasant for their life, it's unpleasant for those around them, and it's unpleasant for their own experience. So you will be seeing this hypomania that is really non-euphoric, and especially when this cycles with depression, even if it's a tight cycle where it's happening on a daily basis, in depression with mixed features, that's a recipe for suicidality. um, Mixed features increases the risk of suicidality by 4 times in both unipolar and bipolar depression. So if they're bipolar, but they're really rapidly swinging back and forth between depression and hypomania, or almost, DMX is experiencing it at the same time. So you're really sad, depressed, but you're also having these racing thoughts and irritability. This is really a recipe for suicidality. Um, and this may underlie the connection between antidepressant use and suicidality, most notably in the pediatric population. Not covering it in this lecture, but there is a doubled risk of suicidality in the pediatric population when taking monoamine agonist antidepressant medications. There's a lot of kind of arguing back and forth about this. There is the black box. Some people will say that, but they'll kind of argue against it. There's there's a lot of nuance to it, but the bottom line is, so suicidality in this population isn't high to begin with, but the absolute risk under these medications, under randomized double-blinded placebo-controlled trials, is that there is a 2 times risk. Now, this is basically taking it from 1% to 2%. So it's not a huge absolute risk, or not a huge relative risk rather, but the absolute risk is a doubling. So, and because again, so young age of onset of depression and depression with mixed feature symptoms indicate kind of bipolarity, and this again is something that may explain why there is a subset of patients that react very poorly to antidepressants, aka the monoamine agonists, aka SRIs, SNRIs, MAOIs, TCAs, why they react so poorly, and that can lead to suicidality. So one of the most important questions to ask any patient with depression: do you have any manic, hypomanic symptoms and or family history of bipolar disorder? And you have to ask them this every patient, every time. Okay? Walk them through those symptoms. Don't just say, and sometimes we just write off the mania. It's like, oh, do you ever have this really kind of really big mood and you spend too much money and you're having unsafe sex? And they'll kind of laugh and they'll say, oh no, I've never had that. You really want to walk that. Have you had these periods in your life where you just felt like your thoughts were going faster than you could keep up with them? The people around you were telling you that you were just a motor mouth and you wouldn't stop talking. You had a real reduced need for sleep. Maybe you were just really, really feeling good and just went days and days kind of feeling good. Or you went days and days where had a lot of energy, but you weren't feeling good. You were upset and irritable and anxious. Get really down in there. Ask them if you have access to family members. Please ask the family members because a lot of times the patients won't recall this or won't kind of go along with what you're saying. You ask the family. The family might sit there nodding and saying, "Oh yes, that's definitely happened." Likewise, family history of bipolar disorder, and you kind of got to get around this. Family members that were hospitalized for psychiatric reasons, who tried to commit suicide, who were known to have a lot of kind of risky, dangerous behaviors that came and went. So really get in there because you do not want to miss this and you do not want to diagnose major depressive disorder when it's a depression with mixed features. So the family history of bipolar will be four times higher in depression with mixed features than in pure unipolar depression. It's highly associated with patients who have two or more hypomanic symptoms during their MDD episodes. Um, the family history is just as common in DMX as bipolar disorder, and it supports the idea of DMX as a soft bipolar disorder and a dimensional rather than categorical view of mood disorders. And this is kind of what I want to get to is that I look at this in terms of it being a dimension. So on one hand, you have a patient with recurrent depressive episodes that never has any hypomania or mania. They just go from being very sad and psychomotor slowed to getting a little better. And then this can go in swings of 2 months, 3 months, 6 months, whatever, all the way on the other end to classic bipolar 2, where they're having long periods of depression alternated by long periods of mania. So if you think of it as a dimension rather than different specific categories, that'll really kind of help cue your thinking in to look for these other symptoms. So the old view was, you know, if they come in and they tell you all these symptoms, and this is how they end up with 5 diagnoses of ADHD and PTSD, etc. So they come to you with this long story of agitation and bad dreams and difficulty sleeping, etc., etc. And part of it is, and I have a sad mood sometimes. We clue into that. We're like, oh, I know how to treat this. I'm going to give you an antidepressant. I'm going to give you a monoamine agonist. I'm going to give you an SRI, an SNRI. That's the old view. So you give a little antidepressant, mania is way over there on the other side. Maybe there's a mania with a subsyndromal depression, so they have mania, but they have kind of this underlying sadness. There's that mixed states right in the middle where you're half and half, or the far end where you have depression and maybe just a little bit of mania. And again, this is the old view, and then pure depression. So the new view means that if you have that trace of mania, that's what you want to lock into. That's the one where you want to listen to them listing off all these symptoms. I have difficulty concentrating, I get anxious, I get sad, and sometimes I'll go 2 to 3 days without sleeping, and my mind will move so fast I can't keep up, and everybody tells me I'm talking too much. That's when you can clue in on a single symptom, because mania is diagnostic of a major diagnostic category. That's when you start. This says start with the antipsychotic. I would say start with lithium. Don't be afraid of lithium, but because lithium is also effective in depression. So, um, so either way, yeah. So your dopamine blocker and or lithium, whatever your mood stabilizer is, and I would scratch out antipsychotic on this slide and change it to mood stabilizer. Um, so so this is what, if you're looking for treatment guidelines for depression in mixed states, here's the issues with it. The existing guidelines and FDA approvals for mixed bipolar disorder refer to the DSM-4 criteria. So this is kind of major depressive episode plus threshold level mania. So they basically say to treat as mania. A diagnosis of MDD implies the use of unipolar depression treatment guidelines. So basically, you're saying, okay, so it's MDD and it's depression with mixed features. It has this hypomania, so I'm going to treat it like MDD, and then maybe add a little something on for mania. That could be ineffective and potentially harmful, as we've covered. So the treatment guidelines for bipolar depression are likely the most applicable for depression with mixed states. Um, so again, look at the clinical trial data. You want to go for maybe those atypical antipsychotics that have the mood stabilizing properties. So treat this like you would treat bipolar, and you're going to handle the mania aspects, and you're likely going to be handling the depression at the same time. And we don't have a lot of studies that are specifically on depression in mixed states, and that's why you have to treat it that way. So I hope this was helpful. This is kind of a new concept. There's a lot in there. I'm always leery of these kind of lectures because I don't want to steer you too far away from DSM-5. DSM-5 is what you're going to be tested on for your board exams. DSM-5 is if your preceptor is grilling you in clinical, they probably want you to give them the DSM-5 criteria. So it's one of those things you have to know it. But I guarantee you there's preceptors out there that if you kind of come to this with some of these topics, you're going to get some interesting opinions because I think sometimes we all kind of pretend like we have to do the whole DSM-5 game. For more than just billing, like that's the way we have to think. And we read each other's notes, and it sounds like we're all doing this and we're all giving 4 or 5 diagnoses. But you really start talking to other clinicians, and they know about these things for a lot, and a lot of them do. And they're already thinking in these terms. So don't be afraid to actually look at what the real clinical entities we are treating in psychiatry are and how we can work around DSM-5 and how we can be good consumers of the research literature and make the decisions that actually benefit our patients. And when you do that, you do good for folks and you feel a lot better about the profession you're practicing in. So hope this was helpful. I appreciate your attention. Be well, and I'll see you next time.